Good afternoon. Welcome. My name is Molly Mitchell, and I am pleased to welcome you to this presentation of TB in Prisons and Jails, Public Health Challenges and Strategies. I'm the coordinator of the Mid-Atlantic Public Health Training Center, and along with the Training Center and the Maryland Department of Health and Mental Hygiene, I'd like to welcome you all to our January Public Health Practice Grand Rounds in 2012. I'd like to just make a couple of announcements before we get started with today's presentation. For those of you who are watching us online, I'd ask you to please just take one moment to sign in so that we can give a better report to our federal funders of who's watching our presentation. And also, if you have emails, if you have questions at any point during the presentation for either of our presenters, please click the link to send in an email, and we'll be able to host those questions after both presentations are done. Also, if you are on our website, please take a moment and take a look at some of our online presentations, which include many of our archived webcasts and webinars, as well as some of our trainings like public health nursing. We also have some upcoming face-to-face trainings, which include community assessment and formative evaluation, social marketing, and getting to outcomes through best process program design and evaluation. So please feel free to take a look on our website to find out more about those. Also want to draw your attention to next month's Public Health Practice Grand Rounds, which will be on ethics and the HPV vaccine, a public health analysis, with Drs. Nancy Cass and Connie Trimble. So we hope you'll join us for that. And with that, I think I'll go ahead and introduce our speakers for today. We're very pleased to have Rear Admiral Newton Kendig, who is a 1984 graduate of Jefferson Medical College in Philadelphia, Pennsylvania. He completed an internal medicine residency at the University of Rochester Strong Memorial Hospital in 1987, and subsequently and subspecialty training in infectious diseases at Johns Hopkins University in 1991, where he subsequently accepted a faculty appointment. Dr. Kendig then served as medical director of the Maryland Department of Public Safety and Correctional Services for 5 years. Rear Admiral Kendig currently serves as both the medical director and assistant director for health services for the Federal Bureau of Prisons, where he has worked since 1996. He is the recipient of multiple U.S. Public Health Service Awards, including the Meritorious, Outstanding, and Commendation Medals. Sarah Burr, our second speaker, is a 1981 graduate of the University of Maryland School of Nursing and received an MPH from Johns Hopkins University in 1987. She worked for 17 years in communicable disease control with the Maryland Department of Health and Mental Hygiene, including serving as chief of the TB control program there. She has worked in association with the Federal Bureau of Prisons since 2005, most recently serving as infectious control officer. With that, I'll go ahead and hand the floor over to Rear Admiral Kendig.
Well, thank you. It's great to be here in Baltimore, Johns Hopkins, and appreciate you attending today's session on tuberculosis in prisons and jails, a topic that is very near and dear to my heart as an infectious disease physician and as a public health officer assigned by the Surgeon General to the Federal Bureau of Prisons. And I think that alone is a recognition of the important role that correctional medicine plays to our nation's public health. Our objectives today are listed on the screen. We're going to briefly give you an overview of what's happening in corrections, both from a population standpoint and tuberculosis, look at recommended TB control measures for the correctional setting. We're going to also give a case review that will give you an overview of steps for doing a contact investigation within a correctional facility, and then what's hot in TB in corrections. What are the things that we're looking for the future to improve our infection control efforts? I know a large part of our audience is the public health community, and I just want to start out with a very general comment that I think, resources are limited in many jurisdictions. So where do you put your energy in public health? And I would like to argue that congregate settings are one of the areas we need to be concerned about, whether it's measles outbreaks in a college dorm, whether it's an E. coli outbreak in a daycare center, norovirus on a cruise ship. Congregate settings are where oftentimes infectious diseases emerge or reemerge. And they also are a strategic site for public health interventions. This is true historically, even with probably the most dramatic infectious disease outbreak in the last century or two, and that is the 1918 pandemic flu, where did it start in the United States? Where did we first see those signs of pandemic influenza in 1918? The military barracks in Fort Riley, Kansas, the San Quentin prison in California. So these are sites that have always been important for public health, and they remain so today. Most of you are familiar with MRSA, community-associated MRSA, methicillin-resistant Staph aureus infections. We now know about. The average non-medical person talks about MRSA. Where did we first see community-associated MRSA in the United States? It was in the state correctional facilities. There were large outbreaks there well before it was recognized, even by academic medicine. The same is true for tuberculosis. It's a concern that we have because it's airborne, congregate settings, and historically, public health has been very concerned about tuberculosis transmission within the correctional setting, which we'll talk about more in just a minute. I did want to highlight the dramatic increase of Americans who are incarcerated. Over the past 2 decades, I think this slide is just very dramatic to see what's happened since 1980 in the US. 2.3 million persons incarcerated in 2010. Almost every one of these 2.3 million individuals is returning to the community, back to their families, back to their children. So obviously a huge impact on public health. And these numbers really just reiterate the previous graphic slide. We would note in the state correctional facilities for the first time, the numbers are starting to decline in 2009 and 2010, but not at all dramatically. And we will still certainly have large numbers incarcerated for the foreseeable future. And a subset of these inmates have untreated mental illness and chronic addiction. And this is important for us, I think, in public health and in TB control, because these are populations that often don't make it to the clinic in the community because of their mental illness, because of their addiction, and where do they show up to get their health care? Oftentimes it is within the local jail or the state prison. So an opportunity for us, again, to intervene with this at-risk population. For those of you who aren't really that familiar with corrections, I always want to make the point that these populations are very eclectic, and it becomes very important when you start to engage in what kind of public health interventions are most strategic. We talk about jails. What do we mean? We mean short-term facilities, pre-sentenced individuals. They're jails throughout the United States in almost every county. So almost everyone in our audience today across the nation does have a congregate population in their local community in the jail setting. We have state prisons. These are sentenced inmates who are put into convicted and placed in our state prisons throughout the United States. And it varies, but in some states, every county has a state prison. So these can be widespread as well. And then there's the federal prison system. We have both detainees, jailed inmates, and also sentenced inmates. I did want to mention briefly about private correctional facilities because increasingly states and the federal system are privatizing correctional health care, or in some cases, the entire facility is privatized. Why is this important for local and state public health? Because these are your stakeholders. Your stakeholder may not be another government official. It may be the private sector, and they become important stakeholders for you to communicate with and engage with. What about the Federal Bureau of Prisons? We have 132 facilities. We've grown enormously over the past 2 decades, largely because Congress continues to federalize crimes. Probably the most dramatic recent was the Adam Walsh Act for sex offenders going to federal prison. We have over 10,000 sex offenders in our system since Adam Walsh was enacted. That's just one example. We have nearly 200,000 inmates incarcerated, and what most people are totally unaware of is that 25 to 26% are foreign-born, largely related to drug trafficking. We have some prisons where 99% of our inmates are from other countries. We have some prisons that over 100 countries are represented among our inmate population. But it's not just the Federal Bureau of Prisons facilities that house federal inmates. Our U.S. Marshal Service is responsible for transporting inmates, detainees primarily, throughout the United States, and they contract with 1,800 correctional facilities, usually local jails. They're all over the United States in the communities represented by our audience today. And there's ICE, our Immigration and Customs Enforcement. Our colleagues there are responsible for managing 11 detention facilities that house criminal aliens, but they also have contracts with 240 additional correctional facilities throughout the United States. A dramatic increase in the number of individuals removed by ICE last year. You can see nearly 400,000. Some of these individuals from other countries were in the United States for a day, some of them for a year. Many of them interfaced throughout all 50 states through our local jail system. As you're probably aware, overcrowding is a huge issue in the United States. And you can see in this slide, with the darker states having the most overcrowding, that almost every state correctional system has some overcrowding. The most dramatic being in California. And you're probably aware in May, the Supreme Court, in an unprecedented ruling, ordered the state of California to release 33,000 inmates because they felt the overcrowding was so severe that the health care may be unconstitutional. That was the first time that had ever happened, but it gives you a sense of how overcrowding is a major issue and a driver and certainly impacts TB control. This is not a federal facility, but it gives you an idea of a common dorm type setting where you have cots that are stacked one on another. I don't have a slide of it, but one of the big concerns in corrections is what we call triple bunking. It's a small cell which has actually, instead of just a bunk with 2 beds, it actually has 3 beds in a very small cell, a big concern in corrections in general. So I'm not going to talk a lot about TB pathogenesis, but just to make sure everyone's on the same basic playing field. In TB, individuals get exposed. Very difficult to predict if you will be infected from an exposure. On average, 30% of family members to an index case, an active case, become infected. But I know from my colleagues here in TB control, I'm always surprised when we do our contact investigation as to who becomes infected and who doesn't. Sometimes the spouse remains uninfected and the friend is infected. So it can be very difficult to predict. Once infected, most individuals for a lifetime are able to wall off the TB bacillus, and although it's alive, it's dormant and does not cause disease. In 10%, it does cause active disease, with the highest risk being in the 2 years after infection for 5%, and then a 5% risk for the rest of your life. So what's happening in 2012 with TB? Well, certainly we are thrilled with the decline in TB cases, which peaked in the United States in the early 90s. And I would just reflect that that also was the time period when we had large-scale outbreaks in state correctional facilities, probably the most dramatic MDR TB outbreaks in the state of New York, where many inmates died and one correctional officer died in 1991. Since that time, we've done a great job in TB control. I mean, it is a very controllable, contagious disease. That is the good news. I think we would say, though, that we can't rest on our laurels. There are still, I think, a lot of reasons for us to be concerned. This is a slide that shows where the hotspots are in TB case rates. I don't think it's a big surprise to this audience. And I don't think this slide is a surprise, but 2001 was the year that we saw a flip of the majority of cases in the United States not being in US-born individuals, but foreign-born. And that has just accelerated over the last 10 years, with more and more on a percentage basis of our TB cases in the United States being among our foreign-born population. And why is that also of a concern? What's happening around the world with TB control? Do they have that nice decline in cases that we just showed for the United States? No, and in fact, we're very concerned about resistant tuberculosis. In some studies, 20% of isolates worldwide, multi-drug resistant TB, resistant to INH and rifampin, 2% resistant to more than just 2 drugs. And you may have seen just recently in the news about India reporting perhaps pan-resistant tuberculosis isolates in Mumbai. Again, this is a concern for us as we have more globalization, more immigration, and the concern about resistance in the United States from other countries cannot be overstated. This is a slide from the CDC that just shows that the cases of TB in corrections are 8 times greater than the general population in the United States. And why is that? It's really not because we're having sustained outbreaks in the United States and prisons we're not. It's because we have high-risk populations who become incarcerated, as I mentioned, often not on medications, whether they're homeless, whether they have AIDS and they're not taking their antiretroviral medication. The first time they're identified with active TB is upon incarceration. But we do have overcrowding, we do have poor ventilation in some facilities, and transmission certainly can occur within the correctional environment. In the soon-to-be released inmate document that was commissioned by Congress, in 1997 estimate in that report said 40% of TB cases in the United States, individuals at some time passed through a correctional facility. So I mentioned most of these points. I think one of the interesting things we found in Maryland and published in Clinical Infectious Diseases, and this was in the state of Maryland, that the longer individuals were incarcerated, the more likely they were to have a positive tuberculin skin test. And we were able to show that conversions occurred more commonly in those institutions within the Maryland State Correctional System that had the most overcrowding. We had a case of multi-drug resistant TB recently identified at intake at a California prison. And I show this slide because, again, multi-drug resistance identified in a Mexican coming into a federal prison. And just with that one case, we had 388 inmate contacts to a multi-drug resistant case. And in a very short period of time, through cars and airplanes, they were dispersed throughout. You can see on the red on the left, 102 deported, mostly back to Mexico, 38 released to California, 43 sent to one of our 116 prisons, 43 facilities involved out of our 116, and 63 were in transit in local jails with the U.S. Marshal Service throughout the United States. So again, that's just one case of TB within a correctional system. When you have these highly dynamic, mobile populations, it is a major concern for public health, and again, an argument that the congregate setting is worth our investment as public health officials. This is a slide where I really wanted to emphasize something that you may not have thought about. We look at those blue states. That's where we want to put our energy, correct? Well, we do as public health officials because that's where a lot of the foreign-born individuals are that have TB. But those of you listening to me who are in the white states on this slide, you're low incidence areas for TB. But my point is you do have foreign-born detainees and inmates that are in your states. And oftentimes, the healthcare providers that are providing care both in the community and the hospital and within the jails and prisons have very limited TB experience. And that's really one of the things we're facing right now with TB. Is it possible in 2012 that you'll have a resident go through a premier university and never take care of a TB patient? Absolutely. Where are they cared for? Most of the TB patients are cared for in the community, and a lot of our residents aren't getting that kind of training. Is it possible for an infectious disease doctor or a pulmonologist to be consulted upon, particularly in one of these low incidence states, and never have treated TB? Absolutely. So that's just, I think, what I wanted to highlight here is just really the importance as TB wanes in our country and our expertise is not what it was perhaps 10, 20 years ago, that we reach out to public health to make sure we're getting the right recommendations. Fortunately, we do have very good guidance with the CDC document from 2006. It's still very current on the prevention and control of TB in correctional and detention facilities. The Bureau of Prisons has its guidelines from 2010. They will be updated in 2012. I'll talk about that in closing. I don't want to review the guidance from the CDC. It's really too much information for this venue, but you can see it really does cover everything in TB control, from screening, isolation, diagnosis and treatment of both active disease and LTBI, discharge planning, and contact investigation. I will note that the stepwise progression on how to do a contact investigation, both in the MMWR CDC guidance and the Bureau of Prisons, was developed by Ms. Burr and is really a superb tool, particularly for frontline nurses who are doing contact investigations within the correctional facilities. The CDC guidance, and so does the BOP, emphasize the importance of an intake screening that looks for TB symptoms listed on this slide. And we're emphasizing more and more they must be language appropriate, as more and more cases are among foreign-born individuals who may not speak English. This becomes a critical issue, that the communication of TB symptoms is accurate. The CDC does divide correctional facilities into minimal risk, listed on the left of this slide, minimal risk for TB, primarily looking at, do you have cases of TB coming into your jail or prison? Do you have an inmate population that's foreign-born or that has other high risk factors for tuberculosis? And then the non-minimal TB risk facilities. For those that are at minimal risk, the symptom screening is adequate. For everybody else, which is the majority of our jails and prisons in the United States, we do the tuberculin skin test or the interferon gamma release assay, which I'll talk about later, or routine chest X-ray screening. This slide really was a document that was produced by Ms. Burr and others and published, but I think it's important. They looked at TB screening, symptom screening in a large urban jail, and were able to show that oftentimes the screening was not done well or documented. And that's why I think it's really imperative, again, for the audience around the nation to really go to the local jail and to look and see what is occurring through the symptom screening process. This can be a very chaotic time for correctional officers. I don't know if any of you here locally have been in the detention facilities here in Baltimore, but oftentimes you can have 10, 20, 30, 40 in our system in the BOP, even hundreds of individuals coming in, sometimes unexpectedly. And so doing an accurate symptom screening can be challenging, but it doesn't take long, and it's extremely important for public health. What about doing routine chest X-ray screening in lieu or with tuberculin skin test screening? This really depends on your population. They're very eclectic populations throughout jails and prisons, and I guess one of my take-home points, particularly to our public health colleagues around the nation, is to really understand the population in your local jail or state facility. Because if you have a high-risk population, if it's largely foreign-born, you may want to do universal chest X-ray screening. We do that in several of our facilities where we have again, 99% of the population coming in being foreign-born. Whether it's cost-effective or not is really going to depend on your rates of TB. The advantage, of course, is immediate isolation and the ability to segregate those contagious inmates from the rest of the general inmate population. Another one of our take-home points is the collaboration that must occur between corrections and public health. And when we get our infection control officers all together from around the country, one of my questions to them in a plenary is, can you name your local public health colleague for TB control, for hepatitis, for HIV? That may be one individual, it may be 3 individuals, but have you personally met with that individual? And so my charge to those of you in public health is, do you know who that individual is in your local jail or in your state correctional facility? Because it really does begin with that trust that, yes, public health is there not to come in maybe and to do an investigation and get the jail or prison into trouble, but is really there to support them in their efforts to control tuberculosis. And it has to be a bilateral commitment and trust that will only develop when there is that personal collaboration. We're now going to shift gears, and Ms. Burr is going to talk about a TB outbreak in one of our federal prisons. I've been with the BOP since 1996. We've only had one outbreak of tuberculosis in a BOP-managed facility, but we always want to take lessons learned from that outbreak, and this is particularly instructive because it occurred among foreign-born inmates in a low-incidence state.
Thank you, Dr. Kendig. I think we learn best from stories, and so I'm going to tell the story of an outbreak that we had in our federal prison, one of our federal prisons in West Virginia, that has a TB case rate of 1.5 per 100,000, about a third the national average. The facility is a medium security facility for men, located in a county with 6,900 persons. In 2008, 52 were tested for LTBI, none tested positive. This is a county with no TB experience. The facility A housed about 1,700 inmates. 22% were non-U.S. citizens, and as is typical in our federal prisons, the majority were Mexican-born. Prior to this, no cases of TB had ever been diagnosed at this facility. We became aware of this outbreak when we identified that there were 2 inmates with active TB identified at this facility. That in and of itself was quite unusual. It turned out that they both had the same antibiotic resistance patterns, a fairly unusual pattern of low-level isoniazid resistance, and turned out to have matching genotype patterns as well. We later learned that this genotype pattern, the MIRO2, was extremely unusual, and only 12 individuals had that pattern in the country. These inmates had been housed in different housing units, which was of concern because we were looking at the potential for widespread transmission. As a result, we sent in a team of investigators to conduct an on-site investigation, and when we found multiple related cases of TB, we ended up asking for the Centers for Disease Control to provide an epi aid to support us. The role that we played in the central office in this investigation is analogous to the role that you in public health are called on to support your local jail and your state prison when dealing with a TB case, particularly one where widespread transmission is suspected. In general, correctional facilities just do not have the expertise to stage and construct and develop plans for a contact investigation. So your help is needed in terms of directing and supporting the investigation. But also correctional facilities in general are stretched thin from a health services perspective and often are not going to have the staffing that's necessary to do an intensive investigation. And finally, data management, which is really quite challenging when you've got hundreds of inmates many of whom have moved on. And TB data collection is inherently challenging because it's so longitudinal, with multiple points in time having to collect data and keep track of it. And so again, public health support with data management is really important. I'm going to run through this investigation in terms of the contact investigation steps that you would utilize with a case in one of your facilities. First, obtaining the SOR case inmate traffic history. Where were they? Did they take classes? Were they involved in work? And then a chart review, interview of the source patient, defining the infectious period, when was this patient potentially infectious, and touring the exposure sites. So let's take a look at what we learned about this inmate's traffic history. He was immediately apprehended after crossing the border by ICE in California in September of 2008. After spending time in an ICE-contracted local jail in California, he was transferred to United States Marshal Service custody, another federal agency, to be housed in an Arizona private prison that the Marshal Services contracts for beds. The inmate spent the next 5 months in that facility. Then briefly, the inmate was what we call in transit with the Marshal Service, in custody in a local jail in Oklahoma, and then finally ended up in the custody of the Federal Bureau of Prisons in our Facility A in West Virginia. We learned through inmate records that this inmate had not had any employment in the facility. He did not have any schooling, but this is often something that we would be looking at in an investigation of this nature. So let's take a quick look at the chart review. The intake to Facility A has a completely negative TB symptom screen. This was a false negative TB symptom screen, and I think is an example of what we found in our study in the pretrial facility, that either these questions weren't asked or they were asked in English and the inmates spoke only Spanish. We don't know exactly what happened, but in fact, this was not an accurate screen. On April 15th, a chest X-ray was done showing multifocal airspace disease, left greater than right, with a 19 millimeter PPD. And then a more thorough screen indicated that this inmate had a cough on and off for 4 months, stating with a translator that he had a positive PPD in the past and that he'd been previously treated. At this point, the response was to prescribe azithromycin, prednisone, and albuterol. Now, I see shocked looks in the audience. This is the instance where this inmate, according to Centers for Disease Control guidelines, should have been isolated, sputums obtained, and worked up for tuberculosis. But in fact, this did not happen. Even if this PPD had been 0 millimeters, we would still consider TB as a possible and likely diagnosis in a Mexican inmate with a cough of 4 months in this chest X-ray presentation. Because 25% of inmates with active TB disease will have a negative tuberculin skin test. This is an image of the X-ray, which is not terribly impressive, showing infiltrates on the left greater than the right. A week later, he states his cough has decreased, the albuterol and the prednisone has helped, and he feels better overall. The chest X-ray remains abnormal. A couple of weeks later, he's seen with a translator saying he is much better, but he still needs to take that inhaler. He's denying fever, weight loss, hemoptysis, and he gets a new inhaler at this point. A few weeks later, again, shortness of breath, says he feels better when he takes those 5-day pills, the prednisone. And so they prescribe that again, prednisone and an albuterol inhaler. A CAT scan was reviewed at the June 11th visit, showing abnormal with multifocal areas of abnormal density throughout both lungs. He states at this time that he's still coughing. However, he says that his cough is less than he when first arrived. He's referred for a pulmonary evaluation and considered for bronchoscopy. This is something that I see over and over again, that rather than isolating, obtaining sputums, we end up going for a bronchoscopy when it really is not necessary. A couple weeks later pass again, translated into the Spanish, my asthma is on the rise. Finally, on July 1st, we recognize that this may be TB and that his cough has not improved, and sputums are obtained and 4-drug TB treatment is prescribed. However, another mistake was made at this point. He was not isolated this day. It took until getting the positive AFB smear on July 8th to isolate the inmate. So I've taken you on this sort of laborious trip through this chart review for a reason, because over and over again in my career, I have been on this journey through a chart where you have a diagnosis of TB and then you look back and you see that over and over again, we're treating for an upper respiratory infection, we're treating for asthma, and we're not suspecting TB. And I guess it's my kind of strong opinion that it's these diagnostic delays that are most important in terms of predicting TB transmission in a correctional facility. The next thing in terms of the contact investigation steps, a critical step that I often see is not performed is the inmate interview. We need to interview this inmate for a couple of reasons. Number one, we need to know how long has this guy been symptomatic? And number two, who has he potentially exposed? And merely the data records that you can get from the computer are not going to tell us about this inmate's daily life in that prison. On interview, we learned that this inmate was coughing, and a new symptom that had not been described before, that he was hoarse since November 2008 when he entered the Arizona facility. He also reported that at the Arizona facility that he had had a 30-pound weight loss. This is really typical of tuberculosis, that you see very profound weight loss. Interestingly, in our facility, we did not see much weight loss, and perhaps it was the multiple courses of prednisone that prevented that. But in any case, he reported that he had never been hoarse prior to November 2008 when he entered that Arizona private facility. In this instance, hoarseness strongly suggests the possibility of laryngeal tuberculosis, a rare form of TB that is highly infectious, that's spread by singing and talking. And this is supported by the fact that the X-ray was in fact not that dramatic, it wasn't cavitary, and yet with the degree of transmission that we ultimately saw, you might have expected a worse X-ray. Okay, so the next step in this contact investigation journey is to establish the infectious period. This is recommended for all tuberculosis contact investigations, but is often less important in a household situation where a person has a pretty stable life. They just have household members, they have work. You don't necessarily plotting it out over time is not as critical. But in a correctional situation, this is absolutely critical because of the inmate movement. Where was this inmate during the time he was potentially infectious? The inmate, the way to establish the infectious period is either 12 weeks before the onset of cough or in the absence of symptoms 1 month previously. So now let's take a look at that timeline that we looked at before in terms of the infectious period. And you will see here on the onset of cough, is in November 2008 when he gets into that Arizona facility. So we go back 3 months to right before he entered the United States from Mexico, was the beginning of the infectious period. And then it spanned all the way from late August, September 2008 to July 2009 when the inmate was isolated. And we can see here that we had multiple congregate settings that were implicated. A local jail in California, the private prison in Arizona, the local jail in Oklahoma, and our BOP facility. Unfortunately, because of the nature of inmate movement, investigations of the inmates that were in those previous facilities was not feasible. It was feasible to do staff investigations, but we will never know how infectious he was, but I suspect he was quite so, particularly during that Arizona stay. So only staff investigations were conducted in those facilities. But the continuation of the inmate interview in terms of where was he and who was he with, who did he spend time with, how did he spend his time. Prior to crossing the border, he lived with his 13-year-old daughter and a wife in Mexico. A really critical part of the inmate interview, when the infectious period spans before the incarceration time, is about community contacts. And always it's critical to ask, particularly, were you in contact with young babies? Were you in contact with HIV infected? Because those individuals are going to be the highest risk for developing active TB. So in this case, we did recommend that the inmate contact his wife and ask that she be evaluated in Mexico. While at Facility A, this inmate was housed in one housing unit only. That was really quite fortunate. Often, because of security reasons, we will move these inmates around to multiple different housing units. So fortunately, we were dealing with only one housing unit for this entire time. Inmates have a lot of time on their hands and they have daily patterns. And so part of the interview is looking at those daily patterns. So on detailed interview, which incidentally took a couple of interviews to get all this information, we found that he spent a couple of hours a day watching movies in a chapel area. He spent about an hour per day in a music room where you could get headphones and listen to music. And we learned that in that music room, everybody was singing this cacophony of songs. So you'd have all these inmates singing at once in multiple languages, and it's quite a theme. And then he also attended a weekly Jehovah's Witness meeting for about an hour a week. The inmate reported no close friends, and often inmates are unwilling to reveal the names of close friends when you do interviews in prison. The next step that is often missed, and I believe is an absolutely critical next step, is touring the exposure sites. This does not require a degree in environmental engineering. This is really just a practical on-site look at what's going on. And I've got to say that every time I have done one of these tours, I have made different decisions about the contact investigation because what I saw tells a story about where air went. Usually it's a good idea to get the HVAC supervisor to come with you so they can tell you where the air goes in the facility. So we toured the A4 housing unit, which shared air with an adjacent housing unit, A2. This was a 64-cell unit with 2-man cells, so about 128 inmates per in the housing unit. There were 2 tiers of cells stacked on top of each other and a very large recreation area with 2-tier high ceilings high. So really quite a large airspace compared to some of the other settings we've been involved in. And there was a small card room off the day room, and the inmate had indicated that he did play cards in this room. We also toured the chapel area, which was a lot of low-ceilinged, small spaces that had the movies and also the Jehovah's Witness meetings. We looked at health services and the dining hall. We also then tried to learn what data was available, like were there music room head-sewn sign-out lists so we could get a list of the inmates that were in the music room? No. But the Jehovah's Witness meetings, there was a sign-out sheet, so we had a handwritten roster of inmates that had attended the Jehovah's Witness meetings. So we pieced together what inmates were knowable. In other investigations, if the inmate has workmates or schoolmates, you can often get rosters of the school or the work to take a look at. Okay, so the next sort of series of steps, key steps in a contact investigation, are identifying your contacts. And what I've found is a tremendous variety over the course of my career in terms of the availability of data and the extractability of data. And I suspect that that still exists all over the country. So, for example, in an investigation that we did in the state of Maryland about 15 years ago, the inmates, when they came into a dorm, it was handwritten in pencil, and then when the inmate left, it was erased and handwritten again. Totally impossible to reconstruct what inmates were with them. And I suspect in some local jails it's still like that. Fortunately, in the Bureau of Prisons, we do have good data systems, but we need special programming to pull out who was actually in contact and housing unit contact with that inmate. But always the first priority are your known HIV-infected contacts. And so hopefully your health services staff know who they are, and we get to those individuals first. We screen them for symptoms, screen them with a TST and IGRA and an Xray. If TB is ruled out, then we treat them presumptively, regardless of the TST result. And then other inmate contacts, and including those who have transferred and released, which is another nightmare. And then finally, staff contacts. Just a comment about staff, it's really challenging to target your investigation, but you want to keep the eye on the prize. While you may end up testing a wider circle of staff than those that were had known exposure for political reasons, you want to keep a list of the contacts that we know were exposed and be sure that we test them at baseline and again at 10 to 12 weeks. In terms of the medical evaluation, as I said, so it's the symptom screen, TST or IGRA, and if positive, obtain a chest X-ray. And a step that I repeatedly see missed is HIV testing of contacts. This is a really important thing to do. And it's been borne out where in the MDR TB investigation, the one related case was an inmate who we identified by universally HIV testing the contacts. And he was the one person that did develop drug-resistant tuberculosis. The next step is calculate your infection rates, and you're looking at that by group. So in terms of your housing, and then you often will separate your foreign-born from your U.S.-born and look at those rates separately. Then looking at the rates with the school, the work, the music room, et cetera. And then treating your infected contacts. And in this case, we treated with rifampin for 4 months because of the underlying isoniazid resistance. A brief look at the results, and this got far more complicated than I'm going to present here today, but in the interest of time, I'm just going to focus on case 1 primarily. So we looked at housing unit A4, which was where this inmate spent most of his time. Of 99 evaluated, 16 or 17% became infected. This is a high rate, particularly given that this was a huge airspace that they shared. Interestingly, A2, which was that adjacent housing unit, had a very low conversion rate. So clearly the transmission through the airways was not a significant thing. We also looked at the housing unit of that second related case that was identified through DNA fingerprinting, and only 1 of 80 of those were had documented TST conversions. And finally, the religious group, spending about an hour a week, had a 6% conversion rate. Many of these inmates, 63, had either transferred out to other facilities or gone to local health, to local communities, and so these were all referred out. Again, it's just a remarkable amount of work to keep track of all these people and conduct an investigation of this nature. And typically we don't see staff conversions. This investigation was a little bit unusual in that we did see 2 conversions among healthcare workers who had one-on-one close contact. Typically in a prison or jail setting, staff is not up close and personal with inmates for prolonged periods of time. And so it was not surprising that if we were going to see conversions, it would be with the healthcare workers who were in close contact with this inmate. A total of 8 related cases were identified, including 3 culture-confirmed cases and 5 probable cases who had abnormal X-rays consistent with TB and negative cultures. And just a little sense of the social links that went on here. So 4 cases were identified in that A4 housing unit. And the inmate with laryngeal tuberculosis, suspected laryngeal tuberculosis, spent a lot of time in that music room, as did another one of those housing unit contacts. Also, the inmate with the matching DNA fingerprint spent a lot of time in the music room, the presumed link for that case. There was another link that was identified through annual testing on an inmate who turned out to be a good friend, an associate from DC who'd hung out together in the prison setting and done walks together daily. So it was presumed that case 3 infected case 5. And then we had cases in 2 other housing units. Again, these individuals were identified through annual testing and not as part of the contact investigation, which suggested that there was spread that went beyond the housing unit that was really not determinable unless you were to test the whole facility. And for a fleeting moment, we considered that possibility because there was clearly transmission had occurred and we couldn't identify all contacts. But that is not a good idea to do that widespread testing for a number of reasons. Number one, you end up with garbage results, a lot of boosting on tuberculin skin testing that are going to be considered conversions, but in fact they probably are just boosts of previous infection. And also it dilutes the focus. The number one important thing for this prison at this time of true crisis was to treat these cases with their active TB. That was the number one thing. They needed to focus on that. They needed to focus on treating the infected contacts. If we had spread to the 1,700 inmates, it just would have been completely diluted the focus. So instead, our plan was with annual testing that we would treat people with TST conversions with that rifampin prophylaxis because of the underlying INH resistance in that source case. And we did symptom screening for the next year on inmates that were leaving. So diagnostic delay was critical here. And one thing that I'm finding across the country is issues related to radiologic interpretation, that frequently the radiology reports do not mention TB in the differential diagnosis. And in this era when practitioners have a limited experience with TB, they may not suspect TB in an inmate with pneumonia. In another transmission situation recently that we had in another prison, the physician the patient had pneumonia, and even though they'd had a 3-month history of cough in this situation, did not know to think TB. And so we've got a lot of effort that needs to be taken to get that basic word out, to think TB, the CDC poster says. And then if a cough is occurring for greater than 2 to 3 weeks, obtain an Xray. And the next step is if that's abnormal, especially pneumonia, infiltrates, consolidation, cavitation, miliary findings, in the correctional setting, that needs to be presumed to be tuberculosis unless proven otherwise. The inmates need to be isolated and evaluated for treatment. A side note, frequently TB patients do not appear ill. Most of those inmates with the culture negative TB in that outbreak were not ill, did not feel ill, but had evidence of TB. And also, just sort of a take-home message, often the weight loss is very dramatic and is one of the first things I look for when I hear about a TB case being diagnosed in one of our facilities. So now I'm going to turn it over to Dr. Kendig for new developments.
Well, thank you. We're very fortunate to have Sarah Burr at the helm with our infection control program, and brings a vast amount of experience from Maryland and has just been incredibly valuable. Hope you found that case review instructive. So many take-home points there, and we're certainly using it from a quality management standpoint to teach our infection control officers around the country. And you know, in retrospect, it always looks like, well, why didn't you think TB? But then if you think, you know what, the last 150 patients that I saw with cough didn't have TB. And we're seeing these TB cases occurring in very low incidence states where I said many of our practitioners have never seen a case of TB in that prison during a 20-year career. So a lot of education that we can all do jointly, I think, that foreign-born populations in particular are at risk no matter where they're located. So what's new in TB control? I think we've talked a little bit about the interferon gamma release assays. In our current guidelines, we do not recommend their use, but we are reconsidering that, particularly for our foreign-born population. It is a blood test. You're stimulating mononuclear cells, cell-mediated immunity with mycobacterium antigens to cause release of interferon gamma. So it is a blood test, different from a skin test, and it has some advantages over the TST. You know, with TST, you've got to do lots of competency assessment and interpretation of that induration versus redness. We've all been there. You need the return visit for the TST read. You have the booster phenomenon with the tuberculin skin test. And in our foreign-born population, you have that confounder of the BCG vaccination, which can give you a false positive TST, which you don't get with the IGRA. So what are the hurdles with the IGRA? Well, one of the main hurdles is logistical, because you can't take 30 samples and leave them at your jail for a month and then send them to the lab. They have to go really that same day. And you have to have a lab locally, usually, that can do that testing. And it's costly. So those are the challenges with IGRA, but there are advantages, and we are looking at how to apply it to our correctional setting in the Federal Bureau of Prisons. I think it's always instructive when you look at guidelines to see how to apply in public health. There may be controversy. For IGRAs, you have the CDC guidelines, you have the guidelines from Canada, and you have the guidelines from the United Kingdom, and you have the guidelines from Europe, and they're all different. So obviously public health experts are challenged with coming up with a concise application, which probably means you have to look at your setting and determine whether or not IGRA should be used and where in a strategic manner, and that's what we're doing in the Bureau of Prisons. There are new diagnostics that are very exciting. On the molecular level, nucleic acid amplification tests are being used more and more and available to jails and prisons. They're most helpful when you have a smear-positive patient. And of course, do you isolate? Yes, but how long? Do you stop inmate movement? Do you embark on a contact investigation, which you can see can be quite complicated? So getting a test back, a result from the lab to say, yeah, that positive smear is most likely M. tuberculosis, can be very helpful and has a very good test rate on a positive smear that, yes, this is M. tuberculosis on your nucleic acid amplification test. If the test comes back negative, but you have a positive smear, then maybe you may want to still isolate that inmate, but not embark on the contact investigation or stop inmate movement until you get the culture results. A lot of exciting things happen with rapid tests for drug resistance. I had the fortune of visiting Moscow recently, and there in some of their prisons, when an inmate shows up with hemoptysis, they're dealing with rates of 5, 10, 15, 20% multi-drug resistance. So if you have 10 inmates coming in with hemoptysis, how do you isolate those 10 inmates? And if your facilities are limited, they are in Russia using the evaluation, molecular evaluation of sputum to determine rifamycin resistance. So I think this has a lot of potential, particularly where you have populations that are at high risk for resistance, to make sure that you're getting as rapid a diagnosis as you can so that you can limit exposure within the high-risk congregate setting. And probably the most historic thing that's happened, at least in my career in TB, is the potential for a much abbreviated treatment course for latent TB infection. We're using our 9 months of biweekly isoniazid in the Bureau of Prisons, and we can do it directly observed within the correctional setting, but that's a long time to give medication. You're probably aware of the short-term of pyrazinamide rifampin regimen that we tried in some correctional settings in the United States, not in the Bureau of Prisons, but that is no longer being prescribed because of the concerns of hepatotoxicity. But I hope you are aware of the New England Journal of Medicine article by Dr. Sterling and the MMWR from December that highlighted the abbreviated course of rifapentine and isoniazid, which you can give with just 12 patient visits, weekly visits. Rifapentine is a rifamycin that has more potency than rifampin against MTB and has a very long half-life, so you can get away with the weekly treatment. Corrections is an ideal setting for this because we know where our patients are. We can bring those inmates or detainees in for their medications and make sure that they get all 12 doses of the INH and rifampin. In the New England Journal of Medicine article, they compared thousands of inmates in either getting the self-administered daily isoniazid with the weekly INH rifapentine, 900 milligrams for both the rifapentine and the INH for a 50 kilogram adult. And what they showed is that the abbreviated course of the INH and the rifapentine was as safe as the daily administered INH, and that the completion rates, not surprisingly, were much higher for the abbreviated course. There was less hepatotoxicity with the INH and rifapentine. There were more concerns about the hypersensitivity reaction and some inmates with hypotension. So as I've already said, this is really an extraordinary opportunity for corrections to provide LTBI treatment to inmates who often have eluded traditional public health networks. Those with HIV infection who are not on antiretroviral therapy. You can't give this regimen if you're on antiretroviral therapy, but one of the things we're looking at in the Bureau of Prisons, particularly for inmates with high CD4 counts, is to give them their treatment for their LTBI first and then starting your antiretroviral therapy. We are concerned about potential adverse side effects that have not been detected because this hasn't been a regimen used in thousands and thousands of inmates, although the studies have been fairly large. But sometimes we see side effects emerge with new regimens when we start treating larger populations. We are going to be integrating this into our updated TB guidelines that we will provide on the internet. Part of the caveat will be very close monitoring of side effects for the INH rifapentine regimen. We're going to coordinate that with the Centers for Disease Control. So in conclusion, hopefully this has been helpful for our audience here locally in Baltimore as well as nationally across the country. I hope we've made the point that correctional facilities should be a target for public health. We have high-risk populations. We have foreign-born inmates across the United States in jails and prisons, and we do know that outbreaks can occur in these congregate settings and eventually affect the community at large where these correctional facilities are located. But by and large, this isn't the big issue for corrections because fortunately we do overall, I think, an excellent job in controlling TB and not having outbreaks, but we're still a very, very critical venue in jails for identifying those individuals who are just lost in the public health infrastructure. They're homeless, they have AIDS, and they're using drugs, their addiction, and they're not going to substance abuse treatment, and they're showing up in our jails where we can identify these individuals and get them on TB treatment. And then, as I mentioned, for prisons, a really critical opportunity, particularly with INH and rifapentine, if it bears out, to give these short courses for LTBI treatment to high-risk populations. And lastly, as hopefully TB will continue to decline in this country and the case rates will continue to abate, we need to keep in mind that many of our healthcare providers have very limited experience in diagnosis and treatment of TB, which makes our role in public health that much more important. Thank you.
I really want to thank Dr. Kendig and also Sarah Burr for a fantastic presentation. At this point in the program, we can now take questions both from our audience here with us at Johns Hopkins as well as those who are watching online. Again, if you are watching online, just click on the link to send us an email question for either of the presenters. We can go ahead and get started if anyone has a question here. Yeah.
Hi, great presentation.
And if you could just wait for the microphone so our colleagues online can hear your question, that would be great. Thanks.
Hi, Carla Alwood from Baltimore City TB Control. A question about INH and rifapentine and HIV positives. Any concern for drug resistance going back to the 2005 MMR where they were looking at rifampin and HIV?
Well, I think there is concern. I remember from the New England Journal article, there was a case of rifamycin resistance, but it was unclear, at least in the article, they said whether or not that was related to the regimen or not. But I do think that that is one of the concerns as we treat more and more patients is, are we going to see rifamycin resistance emerge? And it probably would be a small subset, but you certainly would be concerned about the HIV positive individuals. And I do think that's why it's important, if you have the resources, to really track what's happening to these individuals as they're treated, whether it's in a correctional facility or if it's in local public health.
Okay.
Hi, Lois Eldred from Hopkins Medicine. Sarah, I had a couple of questions about the outbreak investigation. One you may have said already, but what, oftentimes in these low, incidence areas, what's going to happen is they will refer to specialists. What happened at the time that this, index case was referred to a pulmonologist? Did they figure out TB before then, or?
In fact, that inmate didn't get to the pulmonologist, but the CT scan didn't mention TB in the differential, nor did any of these X-rays. And so, and I've got to say from my experience all over the country, repeatedly we're finding pulmonologists and infectious disease specialists that do not know this disease and are giving advice, based on lack of experience, which is problematic.
Right. A second question, you mentioned that, it was not feasible to go back to Arizona to contact, to do more, contact investigation, and yet it was, actually early on where he had lost 30 pounds and was so, evidently clinically ill. And I'm wondering if that's just that because there's so much movement through the prisons that you really can't contact and reach her if it's about expense, or both.
Yes, so the question was what happened in Arizona to this inmate. And yes, this case was missed in Arizona. And I didn't mention, but I was in touch with the healthcare providers at that Arizona prison. They went back and looked. This inmate had come to, just like he had in our system, the 30-pound weight loss was documented. The symptoms were present, and they missed it. As I said, unfortunately, most of those inmates had been deported and so were lost to follow-up.
And just to emphasize, that's why the screening and early diagnosis is so critical in this setting, because most of these criminal alien populations, particularly that are with the U.S. Marshals or with ICE, they're very mobile and they're moving. And when the diagnosis is delayed, you really can't extend your contact investigation to that population, and many of them are out of this country.
Okay. We do have a few questions from our online audience, so I'd like to get to those for a minute. There's a question from someone from the CDC in Illinois. It says, both presenters mentioned the importance of obtaining an accurate symptom screen. Many of the patient populations most at risk for TB are also at risk for poor symptom screen, receiving care in understaffed and overburdened settings, English literacy issues, cultural or linguistic misunderstandings between patient and provider. Do you have any suggestions for a symptom screen that would be more effective for these patients? Do you use something that is written at a lower literacy level, or a screening tool more accessible to patients who may have difficulty giving an accurate medical history, or a screen tool that is condensed for busy providers? How do you train and assist busy providers to get an accurate symptom screen given these competing priorities and obstacles?
You raise all the critical questions, and I can say that I don't believe that we've answered them in our setting, and I don't think they've been answered all over the country. Clearly, language-appropriate questioning is very, very important, and either with a language line or an interpreter. But this merits further investigation. The questions that need to be asked, which is one of the things that we found in our study, and then how best to ask them, very important questions.
And I do think it is a charge for public health that we hire more and more Spanish-speaking providers. And certainly we try to do that in the Bureau of Prisons where we have these high-risk foreign-born populations. But I just think in general in public health, just with all the globalization issues, that we need individuals that can speak multiple language in order to communicate with our at-risk populations.
Okay. And this is a very nitty-gritty question. Have you compared the cost of, and I'll try to get this right, INH/rifapentine X3 versus INH X9 MOS in the prison setting?
It's a complicated question. Certainly the drug costs for rifapentine are much greater than for INH alone. But when you consider the amount of staff time it takes to do directly observed therapy for 9 months versus 3 months weekly, 12 interactions, the answer is we have not done the official cost analysis, but my answer to that would be is you really do have to take into consideration the abbreviated time it's going to take to treat a patient. So we think at the end it is going to be cost effective just because we'll have so fewer patient encounters.
And to give you a sense, so for the federal costs, it was about $110 for INH and rifapentine for the drugs, and about $10 for INH.
Okay. We have more questions online, but I think we probably have some in the live audience as well. So.
Hi, my name is Ann Steele. I worked with patients from DOC and BOP over at Bon Secours, and we had some rollout TB cases. And since prevention through screening is such a big concern, my question is, how are people who are screening inmates educated on the importance of that screen? Because what I'm finding is that the communication between, say, a hospital where I worked and the prison system didn't always make it through all the levels that it needed to make through. Sorry, I'm a little under the weather. So my question is, do you do yearly educational sessions on like the frontline people who are screening these patients? Because it could be an issue of not understanding the importance too of the screen.
Yeah, it's a critically important step, and all systems need to be looking at that. And local and state health departments, you play a critical role in getting to know your providers and finding out what is done. Yes.
And I think the amount of training that occurs is going to vary across the country. In the Bureau of Prisons, we are fortunate to have annual mandatory training, not just for our healthcare providers, but for all of our correctional officers. And Sarah has been instrumental in the infection control portion of that training, which is mandatory and covers not just bloodborne pathogens, but TB and influenza. So I would just say, as much as you're able to educate your correctional systems on how they're providing information, particularly, in a lot of the systems, it's not healthcare providers who are even doing the screening. In some of the systems, it's non-healthcare providers. So you really do need to be aware that you may be, the training might be very different, obviously, for a non-healthcare provider. And your point is that they really do need to understand why. It isn't everyone's, it's really not a hard sell, right? Because this is an illness that can affect everybody, not just the inmates. It can affect everybody who's breathing the air within a jail or prison. So it's not a hard sell, but you do need to make it.
Yeah, right here.
Hi, Tony Sturgis, Montgomery County Department of Corrections here in Maryland. Given the higher prevalence of HIV in correctional facilities and that there isn't widespread testing, of HIV, and a certain percentage of those that are HIV positive will be anergic. Is there recommendations or are there thoughts about recommendations for routine chest X-rays to be performed, particularly in those states that are considered high prevalence?
I think, again, it gets back to my point of really knowing your patient population. First of all, within the prison setting, we're doing universal HIV testing, and the CDC would endorse that. I will say the seroprevalence for HIV is highly variable across the correctional system. So public health officials do need to be aware of that data because it could drive this decision. But one public health strategy is to do targeted chest X-ray screening of individuals who are known HIV positive. We screen everybody with a chest X-ray that's HIV positive, but to get the test and do the chest X-ray, and again, you could for foreign-born populations, you could do the chest X-ray screening.
Okay, I'd like to go back to our online questions. Totally agree that there needs to be a collaborative relationship with prisons and jails. Federal agencies such as ICE have picked up prisoners under treatment for active TB disease from our state prisons and whisked them away. Follow-up is impossible because there is no contact person. Treatment is incomplete, and as we know, these people often return to the states, now with potential drug-resistant TB due to interrupted treatment. Where or with whom can state TB control offices interact to locate these persons if they are still in U.S. custody or if treatment has been completed?
That's a common frustration that is being expressed, that inmates are suddenly sort of whisked away in the middle of the night and they're gone, and how do we find them? In fact, there are people to contact. At ICE, there are 2 infection control officers, Diana Schneider and Jennifer Jones. Information on getting in touch with the infection control program there is on their website. Same with the Bureau of Prisons and the United States Marshal Service. One initiative that we sister agencies are looking at is improving the availability of information on contact information. So that's something we hope to make more readily accessible. But in fact, with all of these systems, there are human beings like myself who care, who will respond, will help you find your inmates.
Okay. Great. Yeah, all the way in.
Thank you guys for excellent presentation. Hi, Sarah. But my question relates to information. It kind of hits on some of what you guys have been talking about, but is there a way that information, medical information, screening information collected about an inmate at one facility travels either electronically or in some other way to other facilities and is available to at those other facilities or to other providers?
Dr. Blythe, you ask a difficult question. When inmates are transferred, they generally have what's called an in-transit form. And on that form should be recorded the latest tuberculin skin test result, an X-ray if one was done, any other medical conditions, and any other medications. So that would be with federal inmates. Getting further medical information can often be very difficult, and really the only way is contacting the individual facility and trying to get that information that way.
There's no single electronic record that's used by all.
Yeah, so Dr. Blythe answers there's no single electronic record. So yes, we do, within the Bureau of Prisons, have a single electronic medical record. So if you have an inmate that went from one federal BOP facility to another, yes, indeed, we have all that information and you can get it. For United States Marshal Service inmates that's contracted with that 1,800 local jails, no, there's no common medical record, and same with ICE.
We do have, the electronic medical record does include a pharmacy record, so we would have all the detailed information about TB dosages. The Healthcare Affordability Act does require, the federal agencies to develop electronic medical records that are interoperable. that's a long-term challenge, but at least we do have legislation that is moving us in that direction. So ultimately, the goal would be that we would have this interoperable data elements that would go from one system to another.
Okay.
Good afternoon, Women Accepting Responsibility. My question is actually in two parts. What happens if you have a person who's eligible for early parole or early release prior to being diagnosed, and then sometime in that process they're diagnosed and they begin their treatment? Would that treatment follow them out of the system?
Sure. So the question is about referral once a person's diagnosed with TB. And indeed, if someone is in the midst of a diagnostic workup or has been worked up for TB, ideally a referral will be made. We make every effort in our system to do that. And in fact, we work very closely with two international referral agencies, Cure TB and TBNet, to make referrals to other countries. That system breaks down a lot, though, in some of the smaller prisons and jails, I know from personal experience.
We have a couple more questions online. Wondering, as part of the contact investigation, whether the TB authorities in Mexico were contacted?
In general, the CDC, the Mexican health authorities do not do any follow-up except for treatment of active TB disease, or occasionally if there were like a known HIV-infected contact to our MDR-TB case. But the resources in Mexico do not include contact investigation and treatment of latent TB infection. So yes, they will respond, and they do often beautifully with cases that are diagnosed with active TB, but not latent TB infection or contact studies.
Okay. And then this is another question, I guess, for Sarah about the case that was highlighted. Were there any cases identified in the other states where the inmate had been housed? Have any cases among inmates surfaced around the country with similar PFGE patterns?
At this point, no. Although we recently have identified a possible a case at our facility A just this week. It's a possible case that's related. I do suspect that over time, inmates with the same DNA fingerprint will be identified, or former inmates. It just seems extremely likely, but we haven't heard of that yet.